Hello, my name is Parth Narendran. I'm a diabetes doctor and a researcher here at the University of Birmingham in the UK. And I've been asked to speak on the role of autoantibodies in type 1 diabetes, really on their clinical significance and how we can use them in research. So I've got two or 3 minutes on this. So the aim of these 2 minutes is to understand what the type 1 diabetes autoantibodies are, recognize the usefulness of measuring these for clinical care, and also their usefulness for research in diabetes. So here is a natural history of type 1 diabetes. As you know, it's an autoimmune disease. It's a condition in which the immune system targets and attacks the insulin-secreting beta cells in the pancreas. And people with type 1 diabetes are born with a genetic risk, and we know some of the genes that are predisposed to type 1 diabetes. There's some sort of immune activation that activates the immune system against the beta cells. And then there's a gradual appearance of these autoantibodies, which can then, with time, progresses to type 1 diabetes. And I'll come back to this slide shortly. But essentially, that's the natural history of type 1 diabetes. And as we go through the stages here, there's more and more loss of the beta cells from the autoimmune process and gradual rise in glucose until it satisfies the ADA criteria for diabetes on glucose values. Here are the diabetes autoantibodies, and here is a picture of a beta cell. And the autoantibodies target specific proteins within the beta cell. So here's the cell, the plasma membrane of the beta cell. Within that is the insulin secretory granule here, which is held within a secretory granule membrane. And within the beta cell also are microvesicles. And the GAD protein, GAD65, which you may have heard of, is a protein within the secretory microvesicle of the beta cell. The IA2, or protein tyrosine phosphatase, is the longer name of it, is a protein within the secretory granule membrane. The zinc transporter 8, another protein you may have heard of, is also in the secretory granule membrane. And then the fourth antibody that we normally measure is insulin, the insulin antibody, which of course you recognize is to insulin. And if we look at the frequency of appearance of these antibodies, GAD is present in 85% of adults newly diagnosed with type 1 diabetes. If you're going to do one antibody to check if it's type 1 or type 2 diabetes, then GAD is the one to go for. But generally, here in the UK anyway, what we measure is 3 of them. So we do GAD, we do IA2, and we do ZNT8. We don't usually measure insulin autoantibodies because there's some concern that the antibodies will come up with exogenous insulin treatment. And often by the time you're seeing them in clinic, they've already started insulin. Interestingly, insulin antibody is one of the first to come up, particularly in children. So in children, it can be useful if you're able to get a sample before insulin is measured. But here in the UK, we measure GAD, IA2, and ZNT8. We do all 3, and roughly 80 to 90% of newly diagnosed people with type 1 diabetes will be positive for an antibody. And that's useful because it can be difficult to tell the difference between type 1 and type 2 diabetes, particularly in adults. And the measurement of antibodies is useful. But remember that a negative antibody does not mean they don't have type 1 diabetes, because there is this elusive 10% that may be antibody negative but still have type 1 diabetes. And managing those can be difficult. C-peptide can be useful, but remember, C-peptide is often high at the time of diagnosis. And if you wait a few years for the remaining beta cells to be destroyed, the C-peptide, you can give that a chance to fall, and then you can measure it. So in my practice, if they're antibody positive, then I'm confident that they've got type 1 diabetes. If they're antibody negative, but clinically I think they're type 1, I often think about leaving them on insulin for about 3 years. And then after 3 years, measure their C-peptide. And if it's less than 200 picomoles per liter, I know they've lost a lot of beta cells, and this is consistent with type 1 diabetes. So that's generally how I use antibodies, and in conjunction with C-peptide if the antibodies are negative. How is it useful in research? Well, these antibodies predate and predict the appearance of insulin requirements. So if we go back to this graph here, the presence of two or more of those four antibodies, even if the glucose levels are normal, imply a near 100% risk of type 1 diabetes in the future. So if there's two, so say GAD and IA2 or IA2 and ZNT8, if there's two or more, we know that at some time in the future, they're going to be on insulin. And in fact, now the ADA and the European guidelines suggest that even when they're two antibody positive, even if the glucose is normal, we should call that type 1 diabetes. And the stages here are stage 1, where on the oral glucose tolerance test, the glucose values are normal. If they're two antibody positive and the glucose values are slightly dysglycemic, then we would call it stage 2. If they're two antibody positive and the glucose tolerance tests are diagnostic of how we traditionally think of type 1 diabetes, of a fasting over 7 or a 2 hour over 11.1, that's stage 3. So just to put that into context, currently we're diagnosing people with type 1 diabetes when their glucose values are in the diabetic range. But what the ADA and the European guidelines are telling us is that we should call that symptomatic diabetes because their glucose levels are up. But here, when they're two antibodies, or two or more antibody positive, but with glucose values that are not diagnostic of diabetes, they suggest we should be calling this pre-symptomatic type 1 diabetes. So it does shift the diagnosis or the term type 1 diabetes to a much earlier stage when they're two antibody positive, but even with normal glucose. Now, this sort of classification is not going to give us more people with type 1 diabetes because everyone who's at stage 1 is going to progress through stage 2 and stage 3. It just picks them up earlier and at a stage where we can educate, support, ensure that their insulin start is safe so that they don't present in DKA, but also gives the opportunities for immunopreventative therapies. As some of you may be aware, there's now an immunoprevention drug that can be given to children at stage 3. At stage 2, where they're dysglycemic, and that delays the need for insulin by 2 to 3 years, and that's licensed in North America currently. But just even though it's not available in the UK, sometimes screening is useful because we can then tell families that their risk of moving on to insulin, the 5-year risk if they're stage 1 is 45%, and 75% if they're stage 2, and the 10-year risk if they're stage 1 is 70%. So this the use of antibodies here in prediction is really coming up, and there are a number of European programs as well as North American and Australian programs that are now up and going in the research setting to explore if prediction can support the ongoing care of our patients by moving the diagnosis early. So I hope that's useful. So I've told you a little bit about what the autoantibodies are, how we can use them clinically, and where they currently sit in the research space. And I'll stop there. Thank you very much.